Yeah. So these are my disclosures. I really have no financial investments, but I am a consultant for a number of industry companies. What I wanted to show you was how recent gene therapy is. I think this will have an impact on you because the first gene therapy that was ever approved for human use was in 1990. That was a clinical trial, and 5 years later, it was shown to be the first successful gene therapy, and this is for subacute combined degeneration, or the bubble baby. We did our the first FDA-approved gene therapy was for retinitis pigmentosa, and I said ours was the first yesterday, but that was for the first systemic gene therapy. This is direct injection of the gene into the eye. The first gene therapy trial for muscular dystrophy was one that we did. Let's see if I can get this. This does, yeah, this pointer yeah. The first gene therapy trial we did for muscular dystrophy was back in 1999, and I like to show that because again, it emphasizes how recent this field is, but a great disaster happened at that point in time that really set back the whole field, and that was the well-known, I don't know how many of you are aware of that, but that was the Jesse Gelsinger death from immune response. And what's often confusing is that was using a virus called adenovirus. From that point on, virtually no single genetic form of mutation or genetic disease was ever treated again with adenovirus. We switched, and you just heard a few minutes ago, the name of that virus is adeno-associated virus. It's very different. Unfortunately, this virus has advantage for carrying genes, but AAV is much safer. It doesn't cause any human disease, and that's the power of transferring genes with that mutation, with that virus. I want to show you two different things that have led to the path of where we are today, and that had a great deal to do with how we handled gene therapy in the clinic. And one was back in 1999. I mentioned that we started, we started with the sarcoglycans. And the sarcoglycans, the reason we started with this, and we carried it through several other trials, was because sarcoglycans are very much like Duchenne dystrophy. They have an integrate relationship with the Duchenne gene, and they have one phenotype or one clinical presentation that's very much like Duchenne and one very much like Becker with calf muscle hypertrophy. So it's a good model to start with, and the whole sarcoglycan fits in AAV, or adeno-associated virus. And one of the important things to realize about gene therapy that was a bit alluded to in the last presentation was, here's the DNA that we put in that replaces the gene, and it has, and this is called a cassette. And when we put this into the gene, into the virus, this is called the vector. So we have the gene plus the virus that make the vector that delivers, and in this case now, it has none of the viral genes. It has only the gene of interest. And you'll see, I'll talk about this gene and the SMA gene and the Duchenne gene. So all of them are similar in this. They all fit in adeno-associated virus. Now, when we first started gene therapy, in the very first trials we did, because of the Jesse Gelsinger affair, actually, we walked through gene delivery in a very stepwise fashion. We started with gene delivery directly into muscle. Then we moved to isolated limbs, and now we're doing somatic gene therapy. Somatic gene therapy has its impact because it can get to every single muscle and in the body, and that's what we want. And this is just, I show here by example. Then we injected the gene into a foot muscle with ultrasound guidance, and we had very good gene expression. And you've seen this picture before. I've seen multiple other presenters have shown you this. But this green around each individual muscle fiber is the gene replacement versus the opposite side. In this case, we injected the gene on one side, and we injected placebo or saline on the other side. But one of the things we learned, every time we've ever done a gene therapy trial, whether it's intramuscular, whether it's isolated limb, or whether it's systemic, we learned something very important. And in this case, we learned that we can't always be successful because exactly why there's no gene expression. In this case, there's no gene expression because there was pre-existing immunity. The patient had been exposed previously to AAV, and everyone in this room could have been, or anyone in this room could be exposed to AAV. So this is an important lesson that we learned that was not known at the time we did these first studies in 1999, the year 2000, and 2009. Really good at this. But here we see at the second day after gene delivery, we had a big immune response, and again at 7 days later. An immune response, ordinarily, if you get inoculated or have an immunization against measles or against any kind of virus, you usually get an immune response out at 2 to 3 weeks. This tells you that the patient had pre-existing immunity. They also had a very high antibody titer, and the numbers don't mean anything here. But this is an astounding number here at 7 days compared to other patients in this trial. So we learned from that all patients entering gene therapy trials, and if you come to our center and are a candidate for gene therapy, we test you for pre-existing antibody to AAV that might impact the gene delivery. That's one lesson. The second lesson was one we learned from a dystrophin or a DMD gene therapy trial, and here I am injecting the gene into a muscle guided by ultrasound. This was in 2006, and what we found here was we were always taught that don't worry about dystrophin-induced immunity. You don't, because all boys who have Duchenne dystrophy have what are called revertant fibers. They have a secondary mutation, which is very much like gene editing or exon skipping, and they'll have some dystrophin expression present in muscle in what are called revertant fibers. But here we learn that isn't true. They have revertant fibers, but the revertant fibers don't protect against all dystrophin. This is our cassette here, and I won't explain this to you entirely because there's really not time, but this is the part of the cassette or the vector that expressed right into a patient's deletion, and guess what? New protein was produced that caused an immune response. So the second lesson was that patients should be screened for pre-existing immunity to not only the virus, but to the transgene referring to the gene that we put in and the product produced by the gene. So 2 lessons to start with. And we moved along in our attempt to be successful in gene therapy, and we had a big winner. This was in spinal muscular atrophy. Now this was one of the first trials that ever delivered virus in a very simple way. We take infants, take them to the intensive care unit, put a catheter in their hand and inject the virus directly into the catheter, even away from their body, in a sense. So it's a painless procedure. And this is what a spinal muscular atrophy baby looks like. They can never go beyond this stage. They have severe body hypotonia. They can't move. They have no head control. They can't swallow, talk, and 50% of them die by 10 months of age, and 92% die by 20 months of age. And here was the result of our clinical trial. And I just wanted to emphasize what can be accomplished with gene therapy. We did 2 cohorts, which is common in gene delivery, but that's not the point of this slide either, nor are the numbers, except to emphasize that 2e to the 14th vector genomes per kilogram was the highest dose of virus that had ever been given in a human trial. And people said that we shouldn't be giving this much virus, and the person who did the study with Jesse Gelsinger personally called me and said, don't do it. And we had very good data to show that we had no toxicity when we delivered this, whether it be in mouse, dogs, or non-human primates. So we were confident. And now we have kids. This was at the end of 2018. We had patients living out to almost 4 years now, and that's the longest anyone's lived. This patient's almost out to 5 years of age. So we had very good success. All patients survived in that trial. And there's the point. And this is what they look like. I like to show this slide because this is what I call our American Ninja Warrior. This patient was treated at 4 weeks of age. The mother had known that she was a carrier for the disease, and she checked the baby in utero, and when she did that, she came to us and said that we had started the trial. This was the 11 of 15 children that we treated in this trial, and he's completely back to normal. Another one that we treated at 8 weeks is also back to normal. So the success of this was profound and recognized really worldwide. This was a paper we published in the New England Journal showing the success. This is the other little girl. She was with me the other day in Columbus when we had a celebration as we evolved toward the recognition of this gene therapy trial by the FDA. So now we have, this is an approved trial, and the reason I show this is now in Ohio, we have an SMA Newborn Screening study, and this was the first baby we did treated at 25 days of age, and now she's 3 months of age and has no symptoms of SMA. So if we treat babies now at newborn, we can completely reverse the disease. And yesterday, as I said, was a huge day in the gene therapy world, because now we've gone from Jesse Gelsinger, who shut down gene therapy, to now to gene therapy that is accepted by the FDA for systemic delivery. So where are we now in the Duchenne field? Well, we're moving toward what's important about the SMA, and the reason I showed it, is establish the principles of what we can do for gene therapy. And I'm not one generally to talk about awards or anything, but I recently did get an award from the American Brain Foundation on the basis of the SMA and our Duchenne work. It's called Cure One, Cure Many. And what that really means is that by showing what we did in SMA, we can take the same principles there and apply them to other single genetic diseases using the same principles. And that's exactly what we've done now in Duchenne dystrophy. This very large dose of virus we gave for the SMA, we're also treating Duchenne and limb-girdle patients. And I'll show you a little bit of the Duchenne results. This is the same thing I was talking about. This is the cassette. Here's the Duchenne gene. Now, one of the things that's already been mentioned is that this is called microdystrophin because the entire Duchenne gene is the largest gene in the human body. Now you tell me why that happened, it's hard to believe that this disease that many of us have been devoted to for, well, I saw my first patient in 1969, and I've been trying to make a difference for all of these years. And it turns out to it's the biggest gene in the human body. Unfortunately, it won't fit in AAV. AAV has a limited capacity, and we don't need to talk about numbers. We can talk about it in the panel. But we have to alter the gene to a form that we think will work effectively. And we have tested this more than 1,000 times, and it does seem to work very well. And we put this in a virus in AAV, and now we have this vehicle, this vector that's carrying the gene, the microdystrophin gene. And we tested it experimentally multiple times, really thousands of times in the laboratory. And I was interested in the gene editing data a minute ago because it very much reflects what we see in AAV microdystrophin delivery. The heart seems to be very receptive to gene therapy. And I think part of the reason the heart is receptive to gene therapy is it's different than skeletal muscle. Skeletal muscle is a long muscle fiber, and it has multiple nuclei along the way. And trying to get the gene to every one of those nuclei is more of a challenge and an obstacle. The heart muscle has one cell and one nucleus, and it's easier to get full efficiency of expression of the gene in the heart muscle. In diaphragm, though, we get very good gene expression, and these are some other muscle groups that have very good gene expression. But just to point out, here's the heart gene expression. The rest are about 60%. So we took this then to clinical trial, and we worked closely with Sarepta. And incidentally, we did also, I worked with Sarepta on exon skipping that we use for Teplerson or exon dis 51, as many of you know. It's a little like CRISPR, only CRISPR, we hope, is more efficient than exon skipping. Exon skipping can change the natural history of the disease, but it's not a home run by any means. And in the gene therapy trial, we have to create criteria for the clinical trial. And in the first open label trial we did on 4 subjects who were 4 to 7 and had confirmed mutations, no antibody to AAV, and didn't have a mutation that would respond by producing an antibody to the virus transgene that we put in. We had very good gene expression, actually much better than we expected. These are the first 4 boys that we did, and they had over 80% gene expression. These are muscle biopsies from the first 4 boys. Quite astounding and looking very promising as we move forward. And here's the normal control. You can see the intensity and the number of fibers that were expressed here. And this is the functional data. One of the best methods for improvement of function. This was data at a little bit different for each patient. It was dependent on the time of enrollment. Here, this is at 9 months. This is 186 months, and this is 3 months. We're now out to a year, and we've had consistent results. But the North Star, the North Star assessment considered to be one of the most sensitive to show improvement, and we had rather dramatic improvement. This is the mean of the patients who enrolled in the first part of the trial, 33% improvement in those patients. We have maintained this now at a year, and then time to rise, 4 stairs, 100 meter and 10 meter. And so all of them now all these time points have improved in the first 4 boys. And the reason I show this is, again, it's basically in response. I'll show this at one of the scientific meetings because of this dose of virus where we were criticized for using so much. Not only was I criticized for using that much virus in AAV, but had the same response from the same person actually in moving toward the gene therapy trial for Duchenne. And here this is immediately post-gene therapy. Here are the IVs in the hands. We inject the gene into the catheter here, and it's extremely well tolerated without toxicity. And here you can see this is pre and post gene delivery. In terms of the Gowers, we get very, very profound results. This is 2 months post-gene therapy. One of my Chicago participants who I dearly love, and here he is basically playing equivalent to soccer. And another patient we had who's going upstairs early, right after gene therapy, and there he's doing reciprocal stairs 60 days post-gene delivery. So we have had very good results. We've moved on now to a 24-patient clinical trial where we hope that we'll have the same outcome as our SMA trial, where we'll have approval of product. We have very low side effect profile. The one that we do have, and this was kind of mentioned in the last talk as well, that the gene goes everywhere. When we put the gene in, it goes to every organ. That's one of the reasons why we have to use large doses. Large doses will make it possible for the competition is really with the liver. The liver is your clearinghouse for all toxic agents that get in your bloodstream, and a lot of it goes to the liver. We have had elevated liver enzymes. The first time that was ever shown really was in our SMA trial, and we've learned now that we can suppress that with corticosteroids, and the boys are already on steroids. So it depends on their dose that we ratcheted up to a dose of that is equal for all patients during the trial, and then they go back to their dose they came in with on the trial. 3 of the 4 boys in the first cohort developed elevated liver enzymes. No other serious toxicity, and no other clinical laboratory abnormalities. Some transient nausea, which we think is from elevating the steroids in the first week. So at this point, things are looking very promising in the gene therapy world, and it's been one of my passions to make it happen, and it looks very promising right now. So I'm pleased to be here. I'm here because of Rick Moss. I've known him for many years, and I think he has done an incredible job. He's as devoted to the disease as I am, so I think that it's a good partnership. So I'll stop there. Thank you very much.